The assessment of the hand and wrist is quite a complex assessment, only because there are so many joints to consider. When you look at the anatomy of the wrist and hand, you have to consider the inferior radioulnar joint, the radiocarpal joint, the midcarpal joint, the carpometacarpal joint of the thumb. You may need to go on to intercarpal joints or up as far as the metacarpophalangeal or interphalangeal joints. Each individual joint is not particularly complex to assess on its own, but it's the combined action of some of these joints that makes the wrist and hand assessment such a complex task. If we start off looking down at the wrist, the basic anatomy of the wrist includes the assessment of the 8 carpal bones with reference to the radius and the fibrocartilaginous disc. Each joint contributes to the overall movement of the functional wrist joint. So when we talk about assessment of the wrist joint, we talk about assessment of the radiocarpal joint, the midcarpal joint and the intercarpal joint. And often included in that, we have to consider the inferior radioulnar joint. The bones of the wrist are organised in 2 rows. So over here at the bottom of the radius we have the scaphoid, lunate, triquetral and pisiform. Pisiform is a sesamoid bone, remember, that sits in the tendon of flexor carpi ulnaris. And then we have trapezium, trapezoid, capitate and hamate. Radius is down here. The ulna doesn't actually contribute to the wrist at all. The ulna itself contributes to the inferior radioulnar joint, but there is a fibrocartilaginous disc that separates the ulna from the proximal row of carpal bones. The ligaments of the wrist there are a number of ligaments of the wrist, and they can basically be divided up into palmar and dorsal intercarpal ligaments. There's the collateral ligaments, the radial and ulnar collateral ligaments. There's the palmar radiate capitate ligament, this structure here, for example, that holds the concavity of the carpus. Then we've got the radiocarpal and ulnar carpal ligaments. All of these ligaments need to be considered. On the whole, ligaments on the anterior aspects of the wrist are too strong to get injured. It's the dorsal ligaments that commonly get injured. There are superficial ligaments as well. Again, there's the radial and ulnar collateral ligaments. There are dorsal and palmar radiocarpal ligaments, and again dorsal and palmar intercarpal ligaments too. There's a large number of muscles across the wrist. Up here we can see on the anterior aspects, we can see all the flexors passing under the flexor retinaculum, the only exception to those being palmaris longus and flexor carpi ulnaris that goes off and invests pisiform. And on the dorsum of the wrist there is a wide array of tendons that pass under the extensor retinaculum. Point to note that as these structures pass under their respective retinaculae, they do so encased in a double layer of synovial membrane, the synovial tendon sheaths, and they are very commonly irritated with overuse injuries, people who type too much, people playing PlayStation, texting and so on and so forth. Fractures around the wrist and hand are not uncommon, in particular fractures of metacarpals or phalanges. The carpal bones themselves can fracture. The commonest one to get fractured is often scaphoid, and avascular necrosis of part of scaphoid or avascular necrosis of lunate is not an unheard of condition. In addition to the extrinsic muscles of the wrist and hand, we must also consider the role of the intrinsic muscles of the wrist and hand. The muscles of the thenar eminence over here, the muscles of the hypothenar eminence over here, and then the intermediate muscles, the interossei and the lumbricals. The assessment of the wrist and hand follows a similar pattern to any other joint. We start off observing, looking for any deformity, swelling and so on, and then move into the movements. Particular points to note are whether the joints are moving in their correct planes, and what the relationship is between adjacent joints. So if somebody's curling a finger up, for example, does the distal interphalangeal joint contribute as much as the proximal interphalangeal joint, and so on. The wrist joint itself, the movements we must consider are flexion, extension, radial deviation or abduction, and ulnar deviation or adduction. The approximate axis of movement passes through the centre of capitate. When we consider movement of the wrist, we shouldn't just consider the physiological movements, but it is important to understand the arthrokinematics of the wrist, in particular that of scaphoid, capitate and lunate. All of the bones of the wrist joints obey the same concave convex rule that we see in any other joint. When looking at radial and ulnar deviation, we can sometimes consider the wrist joint as a whole, or the bones of the wrist joint as a whole. So it's like a big circle rolling and sliding relative to the radius. One of the aspects of the hand that's often not considered are the actual arches of the hand. There is a natural concavity to the palm of the hand, and this is in part maintained by the flexor retinaculum and the deep ligaments. Loss of this natural concavity can often lead to problems such as carpal tunnel syndrome, where pressure is applied to the median nerve as it passes under the flexor retinaculum. The concavity of the hand is important for normal functioning, for prehension. We have this degree of concavity to allow a degree of opposition of thumb and fingers. This diagram illustrates how the metacarpals work. The second and third are generally the least mobile. The first metacarpal is the most mobile by a long way. We have a synovial saddle joint between the carpometacarpal joint here, and that allows flexion, extension, ab and adduction, but there is also a component of conjunct rotation that occurs at this joint, and normal movement of the thumb is important for normal prehension. The fifth metacarpal is also a very mobile joint, with it also allowing a component of opposition. Here we can see the arthrokinematics of the thumb. It's a synovial saddle joint, and so in the movements of ab and adduction we have roll, anterior roll, accompanied by posterior slide. With flexion and extension we have the movements of flexion being accompanied with ulnar slide. When considering the fingers, the metacarpophalangeal joints can also be considered as ball and socket joints. They're condyloid joints. They're classified as condyloid joints, which are modified ball and socket joints. And again, we must consider the arthrokinematics of these joints as well as the physiological movements. The relationship of the extensor digitorum tendon to movements of these joints is also important. The extensor digitorum tendon, as it passes over the metacarpal head, creates an extensor hood, and the extensor hood itself has a role not just as a protective structure, but also because the lumbricals insert into it. It has a role in creating movements of the interphalangeal joints. Normal movement of metacarpophalangeal joints and proximal interphalangeal joints and distal interphalangeal joints are essential for normal prehensile activities. When assessing the finger, wrist and hand, be acutely aware that the cervical spine, the shoulder joint, the brachial plexus, the elbow and the radioulnar joint can all refer pain into the wrist and hand. It's not at all uncommon. So, when we look at the assessment itself, we start off with a typical subjective questioning. For example, what's the current situation? What do you feel? What are your symptoms? Is it pain? Is it stiffness? Is it loss of function? How did you injure it? Is it an overuse or is it a traumatic injury? If it's traumatic, does it require an X-ray? On completing the subjective assessment, we move on to the objective assessment. And the objective assessment follows a similar pattern to any other joint. We start off looking at posture. In particular, we would focus on posture of the upper quadrant and cervical spine. as these areas can refer down into the wrist and hand. We then move on to movements and resisted muscle tests, followed by special tests, functional activities, and then finally palpation. When looking at the movements, we must consider the radial ulnar joint, so we must check that the patient has complete pronation and supination. The wrist, the physiological movements are flexion, extension, ab and adduction, or radial and ulnar deviation, and the combined movement of circumduction. We must check movement of metacarpal relative to carpus, metacarpal relative to phalanx, and interphalangeal joints. At metacarpophalangeal joints, we must also check ab and adduction. And at the carpometacarpal joint of the thumb in particular, we must check the ability to ab and adduct, flex and extend, as well as the passive ability for it to rotate. Failure for it to rotate effectively will lead to impairment of the movement of opposition. There's a wide variety of passive movements that we can perform at the wrist and hand. Any joint can be moved in an anteroposterior or posterior-anterior direction. The wrist joint, rotation of the wrist joint must be considered. Distraction of the radial ulnar joint must be considered. Medial and lateral glides at the wrist joint are also important. Quick tests can include weight bearing, for example, press up, throwing, catching, and to test quick activities. Since the primary function of the wrist and hand is prehension, grips must be assessed, and these can be broadly broken down into precision grips, those in which the pads of the thumb and the fingers are opposed, or power grips in which the extrinsic muscles are key components that flex the fingers around the relevant object. Here are some examples of various grips: a hook grip, fist, spherical grip, palmar prehension, lateral prehension, tip prehension. When we move on to special tests, there aren't many to consider at the wrist and hand. The most notable one is Finkelstein test, which is for de Quervain's disease. In this situation, the subject grasps their own thumb and they ulnar deviate. They actively ulnar deviate. We're looking for pain here, and this tests for irritation or tenosynovitis of the abductor pollicis longus and extensor pollicis brevis tendons. Tinelstein has been done at the elbow. You tap along the course of a nerve. A positive test is where tingling is noted along the distribution of that nerve. The commonest nerve to be impinged at the wrist and hand is the median nerve as it passes under the carpal tunnel. Phelan's test and reverse Phelan's is they're both tests for carpal tunnel syndrome. In this situation, the athlete flexes her fingers to the maximum and holds that position for 1 minute. Here is an example of Phelan's test in which the athlete is placing both of her palms back to back relative to each other. Varus and valgus stress tests at the wrist and digits are important, as these demonstrate the integrity of the collateral ligaments. So in addition to those special tests, we also may want to perform a thumb ulnar collateral ligamentous laxity test, in which we assess the integrity of the collaterals of the thumb themselves. This is basically a stress test to the radial and ulnar collaterals, in which the operator forces ab or adduction. Just like any other assessment, we analyse and we identify a problem list, we plan our treatment and clearly delineate both short term and